Hello everyone. Assalamu alaikum wa rahmatullah. Today, inshallah, we will discuss very important scenario. And I know it's a little bit difficult, but it's very, very important to discuss. And actually, not only for the exam, but also for your clinical knowledge. It's for your work if you will face a case like this uh, in the future. So let's go directly to station number 5. Yes. So you are the ST5 in the department and you have a patient, day 2, post-emergency cesarean section. She was a case of twin pregnancy. First baby was with footling breech, so she was scheduled for elective section, but she came in labor. She was taken to the theater and she was 6 centimeter dilated. She had previously laparotomy for appendicitis and previous salpingectomy for ruptured ectopic. So here we have a lot of risks in this patient and we need to identify the risk. Let's discuss the risk first and then we will move forward. So this lady, she's a case of emergency cesarean section. The emergency cesarean section usually will carry more risks more than the elective one. So if you will tell the patient about the risk during the section with the emergency, you have to tell her that the risk will be higher regarding the injury because usually with the emergency, if like in this situation, so the patient starts to be dilated and the risk of injury here will be higher, right? So injury of the bleeding, risk of the bleeding will be higher, risk of the injury will be higher. Um, and sometimes, even if the patient is fully dilated, sometimes the risk will be higher and higher due to the impaction of the head, and this will increase the risk. So, this is number one. The emergency section is the risk number one. Number two, because the patient is start to be dilated, she's 6 centimeters dilated. Number three, this patient is twin pregnancy. With the twin pregnancy, the uterus is distended. There will be like not distorted anatomy, but there will be like pressure on all the organs and structures. And again, you will not be able to identify well the organs, and sometimes this might lead to the injury. This patient had previous laparotomy with for appendicitis before. So laparotomy itself will increase the risk because there will be adhesions and scar tissue. Appendicitis separately, there is like risk of adhesion and scar tissue in that place. So laparotomy will increase the risk. Appendicitis will increase the risk. Salpingectomy for ruptured ectopic again. So salpingectomy usually it's done by laparoscopy. So laparoscopy will increase the adhesions. If you remember, we have a very, very famous question in part 2 exam, like risk of adhesions after laparotomy. It was around like 50%. And with the laparoscopy and after cesarean section. And if you remember these numbers, so here in our patient, she had laparoscopy, for sure this salpingectomy done by laparoscopy or laparotomy, but more likely laparoscopy. So the salpingectomy itself will increase the risk of adhesions. Ruptured ectopic will increase the risk of adhesions. Laparoscopy, which is done to remove the tube, will increase the risk of adhesions. All of these adhesions will increase the risk of bowel injury, bladder injury, ureteric injury, bleeding, and hematoma formation after cesarean section or bleeding on spot, like to increase the bleeding. Also, the twin pregnancy will increase the bleeding because now it's distended uterus. This will increase the risk of atony. And if you have any atonic uterus, the risk of bleeding will be higher and higher. And while you are doing manipulation, try to control the bleeding, you will hit something. You got the point? So if you will go through this task, you will find like it's full of risks. And not to be surprised, guys, it's like, I will not say a routine, but maybe on weekly basis, you might face a condition, not typical like this patient, but you will have like a patient high risk while you are working here in UK. So at least like once weekly, you will face one lady, not exactly same because it's not like exactly same, but similar with some of these risks, more maybe more than that or less than that. So you will face this situation You need to think about the risk. You need to speak with the patient about all of these risks and keep in mind while you are doing the cesarean section. Such cesarean section, the consultant should attend for sure. You need to have extra staff with you to be available and to anticipate any complication, right? This lady should stay with us like for at least for 2 days after because you are suspecting like complications. So keep her in the ward at least 2 days after cesarean section. Usually any section we will discharge first day, like after 1 day, I mean. Um, Except in some cases, like for example, preeclampsia, we should monitor the blood pressure for 3 to 4 days and then discharge. This lady, because you are anticipating complications at that time, please keep her for a while in the ward with you. Post-operative, the patient starts to have distended abdomen and she's not able to pass flatus. Bloods as follow: hemoglobin 94, there is hyponatremia, hypokalemia, urea normal, creat 82, GFR is 89, so it's like not that much compromise. So still we can accept the 89, right? She's hypotensive tachycardic, so you can think about bleeding, bowel injury, ureteric injury even. You can think about it. We have to keep it in mind, right? But we will rule out things with the clinical picture and also the bloods we have. Right, we have to think about everything: bleeding, bowel, bladder, ureter, and then try to rule. Or more likely, it's not bladder, it's not ureter. The patient can pass urine, the catheter in place, and the urine output is good. We don't have any problem. So we can rule out the bladder, we can rule out the ureter, and then think about the bowel or bleeding. The patient hemoglobin 94, it's not that much bad. Post-cesarean section, twin pregnancy, and have a look on her like pre-operative hemoglobin. It's like very important point. Don't say, oh, the patient hemoglobin is 80. All right, what about her pre-op hemoglobin? Oh, it was 90. It was 95. With the pregnancy, twin pregnancy, this can happen. Even if the patient on oral iron, yes, yes, it can happen. A lot of patients we can see like pre-op hemoglobin is like around 100, and we will consider this normal in the third trimester. It's like up to 105. Um, Post-operative 94, we need to compare with the pre-operative. But if you can see that pre-op hemoglobin was like, for example, 135, no, now there is like sudden drop of the hemoglobin. And you have to have a look on the EBL, estimated blood loss during section. Is it like it can cause this sudden drop? All right, so it's okay. It's explained because of this bleeding during section. But if the EBL, for example, like less than 500 or even up to 1000, it will not make this sudden drop from 135 to 94. You got my point? You can touch this point with the examiner in the exam because it's a differential diagnosis case, right? So the main question was, how about your differentials and how you will manage this case, right? So now we discuss the risks in the patient because you need to do that with the examiner. And we discuss the differential diagnosis and how you will reach your final diagnosis. It's actually the clinical picture plus the bloods, and then you can offer extra investigation like a scan, ultrasound, I mean, X-ray, CT, whatever you want according to the scenario. Right, so in any structured discussion, I think we have a question. Just 1 second to check the chat. Yes, very well done, Shaima. Yeah, refreshed with this information. Midline, the laparotomy 50. The transverse, usually with the cesarean section, previous section, it's 25. As I remember with the laparoscopy, it was like around 2%, something like that. Right? So we have a lot of risk in our patient. As we discussed before, guys, in any structured discussion case, you need to give introduction. You need to give definition of the case or of the scenario you will discuss. For example, here we are speaking about the complications with cesarean section. So just to speak a little bit about the section with the examiner. So cesarean section, it's one of the commonest operations performed in the UK, and its incidence now is increasing. Even in the UK, yes, because sometimes we can offer because of the maternal request. Nowadays, we can see like a lot of patients, they had like bad experience with previous birth, like traumatic birth. And she's, no, I don't want any vaginal birth. I had this instruments or the forceps and I had third degree tear. I was suffering. No, please offer me cesarean section. So it's now a common operation in UK. Nowadays, the good news in Egypt that they will put like more restrictions because in Egypt the risk with for the cesarean section is very very high, or the incidence. Um, so recently, like maybe 2 days ago, they started to think about, no, we need like to put more restrictions. We need to have like documented cause of this cesarean section. Hopefully, the incidence of section will be less. In the Arabic countries, no, they are following the UK. So usually no cesarean section will be done except like with a very strong and documented cause. Cesarean section is a major, and it's a major surgery, an open abdominal procedure. Sometimes the patient will think like it's very easy to open up her tummy and just to take the baby out. But we need to explain to her it's a major procedure, open abdominal procedure. And risk of having emergency section is high now, right? The incidence of relaparotomy after section is around 1%. So it's 0.12 to 1.04%. All of these data, guys, from the TOG article. There is a very nice TOG article published in, as I remember, 2016. I shared this TOG article on the group. It's a very nice, it's only speaking about the injury with the cesarean section, right? Which is like our question in the exam. The most common indication for the relaparotomy is the intra-abdominal bleeding, intra-abdominal abscess, bladder, bowel complication. So this is your introduction. Identify the risk, what we did on the first slide. How about the risks? Our patient having twin, emergency section, section with the 6 centimeter dilated. She's not fully dilated, but she's twin. So more likely, like the babies will pass like before the full dilatation. And also with the 6 centimeters, this will increase the risk, especially for the ureteric injury, right? Having laparotomy before, having appendicitis before, having ruptured ectopic, salpingectomy by laparoscopy, all of these will increase her risk to have injury. Now coming to this very nice table from this TOG article. Okay, guys, it's covering all the complications of the cesarean section. And if you will have a look, guys, you will find all of them scenarios in the exam. So look, it's this table. Every line or section is like exam question. Postpartum hemorrhage, exam question. Sepsis, exam question. Bladder injury, exam question. Ureteric injury, exam question. It's part of the post-operative complication that might happen with the hysterectomy, but again, it can happen with the cesarean section. The management will be different? No, at all. Management will be the same because by the end, we have injury, we have a complication. It's almost the same, right? So having cesarean section will not make any differences. Just this patient will be ops and this patient will be gynae, right? So coming to the complications, postpartum hemorrhage, it's around 5%. How to avoid with antenatal diagnosis of abnormal placentation or having a fibroid. And actually, before antenatal diagnosis, no, antenatal, we need to pick up the patients with anemia, the most common cause of postpartum hemorrhage. So I can add here one point, it's present in the postpartum hemorrhage guideline. If you remember, the first point to avoid will be to pick up the patient, detect the patient at risk, like patient with anemia, patient with fibroid, patient with abnormal placentation. We need to offer meticulous surgical technique to avoid any hemorrhage. And if you have any bleeding spot, secure immediately. Like, don't leave it till the end. If it's like at the early beginning of your section, so you can secure directly. But if it's just before the delivery of the baby, like head delivery, you can deliver the baby and then secure this bleeding point first and then go on with your steps to close. Part of the avoidance also to offer some, to give the oxytocin with the cesarean section, we are giving 5 international unit IV. This is also part of the postpartum hemorrhage guideline. And then if this will happen, how to treat? It's like here, it's summarizing the points. But if you want to know how to manage, we will go with the algorithm from the guideline, right? So we can offer uterotonic agents. We can do the surgical repair of any bleeding point. We can use the balloon tamponade, Bakri balloon, compression sutures, like B-Lenge sutures, or to offer the sutures over the bleeding point. But if we have a tonic uterus, so we can do the B-Lenge, uterine devascularization, and then interventional radiology by doing like embolization, and by the end will be the hysterectomy, our last resort, right? So here it's just to summarize our task today, Bowel, but we are doing like brainstorming and we are thinking about all different scenarios. But if you want more details about the postpartum hemorrhage, for sure it will be the RCOG guideline. Coming to the second complication, which is sepsis. Wound sepsis can happen in around 6.8 to 9%. Endometritis can happen, which is common, like around 4 to 18%. Right? Endometritis, how to diagnose? Endometritis, we don't have any like blood test for that, but the patient will come with bleeding, might come with high temperature, and CRP will be a little bit higher than normal white blood cells as well. And the treatment usually with antibiotic, right? So how to avoid the sepsis? Antibiotic prior to skin incision. Usually we are giving this and it's done or it's given by the anesthetist. So prior to, immediately before skin incision, vaginal decontamination, it's not a routine. It's done if we have rupture of membrane, but it's not a routine in UK, right? But as per the TOG article, we can do vaginal decontamination, meticulous hemostasis, appropriate use of abdominal and wound drains. As part of the sepsis also, we are offering like routine MRSA cream for the patient, nasal and groin. So we will be sure that the patient has no like resistant bacteria on the skin or inside the nose. How to treat? Antibiotic, radiological drainage if we have abscess formation, wound debridement, and relaparotomy, debridement, and wash out. Rarely to happen. I think it should be just for the very, very severe cases and, for example, with like big abscess, right? But usually we are not offering real laparotomy with the sepsis because I believe this will increase the risk for the patient to have another surgery while she has sepsis. The third complication is the bladder injury, and it's around 0.1%. How to avoid? Careful peritoneal entry, avoid bladder flap creation, avoid excessive low uterine incision. Don't go very low. And try, here they put like question mark beside avoid bladder flap. We are just taking like the bladder away from the uterus. And by the doing, you will protect the bladder and keep it down. And also with the evacuation of the bladder. If we have full bladder, so that's why the catheter is very, very important to detect any injury if it will happen, and also to be sure that the bladder will be empty throughout your section. How to treat? Surgical repair for sure. Consider possibility of ureteric damage, bladder drainage, and cystogram 10 to 14 days later. For the ureteric injury, it's around 0.4%. So how to avoid? Correct for dextrorotation prior to uterine incision. Caution with repairing extensions. And part of this, like not only to repair the extension, if you will do like proper C uterine incision, don't go like this in the uterus. So the extension will go up. If you will do it like transverse, the extension will go here and the ureter will be at risk, right? So proper, not C or not U, but like proper C. And also take care while you are doing repair of the bladder injury. How to manage? Once you will have bladder injury, please take urology opinion. And also with the, with the ureteric injury, take care and take opinion of the urology. And even with the bladder, we need to take urology opinion as well. If the case is a ureteric occlusion, like to be sutured or ligated for any reason, suture removal, put a stent, we can offer nephrostomy as well. But if it's transection, like it's like cutting through the ureter, reanastomosis or reimplantation. What is the difference between both of them? Reanastomosis, if you will have the cut in the upper 1/3 or the middle 1/3. But if it's in the lower 1/3, sometimes it's sure to do the reanastomosis and you will do reimplantation in the bladder itself, right? New cystostomy, like you will do new opening of the bladder and insert the ureter inside. So this is how you will do the ureteric repair. It's just a quick revision of all complications. When you will tell the examiner, let's go back to our scenario. When you will tell the examiner, now I'm thinking about it might be bleeding and hematoma formation, intra-abdominal bleeding. It might be sepsis. It might be bladder injury or ureteric injury, but sepsis less likely because the patient, she has no like symptoms like high temperature. Check her temperature. With the CRP, even with the bowel or ureteric injury, it will start to be high because of the peritoneal irritation and peritonitis. So CRP will be higher, but with the infection, it will be higher than that. It will be hundreds, right? So think about bleeding, bladder, ureteric, bowel injury. Here the examiner will say, all right, so if it's bowel, how about the possibilities? So the examiner will take you to the bowel injury because in the scenario, we don't have anything like clear to say it's a bowel injury, right? This is the remaining part. It's the same table, guys. So this table, this one, this part is the remaining part, right? So bowel injury, we do have, or bowel involvement, let's say involvement. We have three possibilities for that. Either injury or ileus or Ogilvy syndrome. So three possibilities you need to cover in the exam. Once you will think about bowel, think about the three possibilities. For the injury, how to reduce the risk? Careful peritoneal entry and a general surgical assistant if you have extensive previous surgery, like in our patient. And you can take the uterus out while you are suturing near the broad ligament. But if this happens and you can detect general surgical assistance, primary repair, resection, and stoma formation. If it's ileus, if you are suspecting ileus, how to reduce this and how to manage. Careful bowel handling. Don't touch the bowel like too much during section and doing like touching everything. No, careful handling. And we can use the chewing gum post-operatively. Exam question. So take care of the chewing gum. It's part of the, it was exam question in the enhanced recovery with the cesarean section, right? So this can reduce the risk of ileus. And how to manage? We need to rule out the serious pathology like Ogilvy syndrome and bowel injury. We can give IV fluid. We can correct the electrolytes. Why? With the ileus, usually you will find electrolyte disturbance like in our patient. We will use antiemetics. Gastric drainage, but if the case is persistent, not immediately. And we need to minimize the opiates or instead to stop opiates. Try to offer the patient another thing apart from the opiates, right? If it's Ogilvy syndrome, how to manage? It's exactly the same like ileus plus we need urgent surgical review. So in the management, you will tell the examiner, I will do all the steps like ileus plus urgent surgical review. And consideration, think about newstegmine. Rectal flatus tube and laparotomy in some cases where it's like the cecal dilatation will happen, right? It will be dilated and the patient is suffering. Sometimes it will be like life-threatening condition. We need to do laparotomy, right? So now coming to our patient. Now the examiner will say, now if it's bowel, how about the possibilities? You mentioned the three possibilities. And now how to manage this case. So this patient should be under the care of multidisciplinary team. In terms of multidisciplinary team, guys, not only group of expert team, not only like we and another department with us. No, here MDT. Why MDT? Because this patient after surgery with a major complication now. We don't know still, we don't know, is it just ileus or it's bowel injury or it's Ogilvy syndrome? We need to run more investigations, right? So multidisciplinary team, including my consultant, surgeon, and it's better to be like a bowel surgeon, a hematologist, anesthetist, specialized nurse, counselor, theater team, if we'll take her back to theater, laboratory team, blood bank team, if you are thinking about any bleeding, so just put it in case of needed. We need to run more investigations. The full blood count, it's already done, but we need to do a follow-up. Like this patient with any complication, usually the bloods will be done on daily basis. We will not do it once. We will repeat every day. Sometimes even we can repeat twice daily in some serious conditions. But here in our patient, it will be like once daily till the patient condition will be like stable, so we can stop offering her the bloods, or it can be offered when required. So full blood count to be repeated, liver function, kidney function, coagulation profile, the CRP to see the trend, if it's rising or it's going down, and electrolytes as well to get like proper control over her electrolytes. The imaging, we need to offer her ultrasound scan. The scan will show if we have any collection in her tummy or lower tummy or abdomen and pelvis. It's a structured discussion. So the scan will show if we have any collection, and it will show us the nature of the fluid. So if it's urine or if it's blood, so the ultrasound will tell us if we have any collection. If no collection, so we will not think about the bleeding, we will not think about it's a bladder or ureteric injury. Sometimes with the injury, it can be minute and no collection, but for sure it will not cause symptoms in the patient. You got the point? So we need to see collection if you will think about it. We might need to offer X-ray and CT here to differentiate between the bowel injury, Ogilvy syndrome, and ileus. X-ray and CT. We will refer this patient to the high dependency unit or even intensive care unit. It will depend on her condition. We need more monitoring for the patient, but at least she will be in the high dependency unit. We need to offer her antibiotics. Antibiotics in ileus or Ogilvy syndrome, not required, but if it's bowel injury, yes, it's required. And we need to give her the fluids in arm and to see if this patient will be able to eat and drink or not. She will stay with us for longer time, so we have to consider low molecular weight heparin during her stay, and we will reassess her again before discharge to see if we can give for like 10 days or 6 weeks according to her risk. Even if she's not, for example, her VTE risk is 1. So we will give to her now during her hospital stay and reassess again before discharge, because maybe she will develop something which will upgrade her VTE risk and score. And now she will be like score 2, 3, 4, like this, according to what she will develop. We need to offer her the fluid chart to check the fluid in and out. And we can put a catheter in place to have like accurate documentation, or if she's not able to be mobile, but if she's able to be mobile or to mobilize, so avoid the catheter, ask her to go to the toilet, and we have like special pot, we can measure the urine. So urine chart, fluid in and out. Now coming to each possibility, here you will find like more details about bowel injury, Ogilvy syndrome, and ileus. So before moving forward, guys, do you have any questions?
Yes, please, Dr. Rana. First of all, happy Teacher Day, as Dr. Thanks, Dr. Zarina, for reminding us. Concerning the low molecular weight heparin, she is already in the hospital and she was already assessed, and she is on already heparin or Clexane. So why I should assess it again? What risk increase if she is emergency cesarean section, and she would continue her low molecular weight heparin? You know what I mean?
Yes. So in case of emergency section itself, we'll give it like score 2, right? So she will be on 10 days. We don't know anything apart from the emergency section, isn't it? We don't know anything about this patient, if she's like a smoker or anything, if she will go back to theater and she will have laparotomy. So that's why we need to keep her, and for how long she will stay with us. So you have to touch this point, to be sure that she's on low molecular weight heparin, and before going home, you reassess her again because some of the complications might increase her risk, right? Like having another surgery, another laparotomy. So at that time, her risk will jump, right? For example, if you will detect bleeding, I'm not discussing this case like only, but generally speaking, for example, a lady, she had a section, right? And it's not emergency. Her score is 1 just for the section, right? So usually we will not give any low
Yes,
molecular weight heparin.
yes,
But if she will, while she's with us, she start to bleed, right? So this is postpartum hemorrhage. Even it will be like even after a while, like after 1 day, after 2 days. Sometimes even the patient can go home and she will come back with bleeding. So at that time, this bleeding will increase her risk. You got my point?
yes,
So that's why reassess again. Any patient, be sure that she's on low molecular weight heparin. Don't assume that the examiner like they understand this point, but they want to hear this point from you because low molecular weight heparin is very, very important.
yes.
Sometimes it can go more. Yes,
And I think if she is going to be operated again, we should touch the point that we should stop low molecular weight heparin before and restart it again.
you can do that in the same spot. Like tell the examiner that we need to be sure that she's on low molecular weight heparin. She will be reassessed before going home. And if we will take her back to theater to have re-laparotomy, at that time we need to stop the low molecular weight heparin at least 12 hours before the laparotomy, and
Yes,
to restart it again 6 to 8 hours or 4 to 6 hours after the laparotomy and
yes.
according to the condition. But it's
Thank
very,
you.
very important. Rarely, to be honest, with the obstetric cases, rarely low molecular weight heparin to be missed because the midwives, they are very, very expert and they know how to manage this point. Even they will remind you, please, doctor, this patient, she needs a low molecular weight heparin. More likely she might it might be missed with the gynae, but with the ops less likely because the midwives, they are very expert in this point. They
Yes,
are not able to prescribe, but they will remind you, please, doctor, prescribe this because of this patient. She has VTE risk 2 or 3, like that, right?
thank you.
Yeah. You're welcome, Dr. Mustafa. Thank you so much for the question. Bowel obstruction, how it will happen, like less likely. Amani, regarding your question, Dr. Amani asking, bowel obstruction is option. So we have the pseudo obstruction, but to have obstruction due to the surgery, less likely, because you can ligate the ureter, but you will not be able to ligate bowel, but more likely to cause injury or to have this pseudo obstruction, right? Okay. So for the bowel injury, immediate bowel injury is like a rare complication, and the RCOG consent advice does not list bowel injury as a serious risk, but rather refers to the possibility of the bowel repair as an additional procedure. But it's still there, okay, guys? So it's still there. Still, it's a risk. And in my opinion, it's we should consider it like a serious risk because it's not a common thing. Usually the serious is uncommon, right? The distended gravid uterus can replace the bowel and it will affect, it will be, or the uterus will affect the bowel position and this will increase the risk as well. Loops of the bowel may be adherent to the anterior abdominal wall, for example, like in our patient after laparotomy, laparoscopy, and all of this stuff. And this particularly if we have a history of a surgery via the midline incision, right? After delivery, the bowel can be damaged during closure, while the uterus being closed, particularly at the angle of the extension. That's why take care, take the uterus out. It will be safer, but it will increase the risk of bleeding. It will give you like false reassurance. When you will take the uterus out, so you are stretching the uterus, stretching the blood vessels. If you will put it back, the blood vessels will be lax, not stretched, and you will find like a lot of bleeding points. So it will give you false reassurance. Take like a good look after putting the uterus back. Taking the uterus out, it will allow direct visualization, right, of the posterior aspect of the uterus as well. It's essential to diagnose the bowel injury intraoperatively, but unfortunately, we have like around 15% will not be diagnosed intraoperative, and you will diagnose it post-operative. Okay? It's vitally important to avoid damaging of the bowel by or with a diathermy. That's why, please, guys, use it like when it's necessary. And don't use it near the vital organs, like near the bladder, near the bowel, near any blood vessel, near the ureter. And if you are able to take stitch suture, it's better than using the diathermy. One of the consultants told me one word. She said, like, it's like this buzzing sound, it's like addiction. So once you will use it, you will not be able to stop during the same section. You got the point? So it's like addiction. Once you will hear the buzz, zzz, 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 so you will keep going with this, right? So try to avoid using the diathermy. Just keep it if it's necessary and use it away from the vital organs. If the bowel injury not recognized intraoperatively, so usually the patient will come with symptoms and signs of intra-abdominal sepsis because of the secretions and fluid coming out, and it will cause like peritonitis. It can be delayed for several days in the case of perforation following diathermy injury. Why? Diathermy, usually it will take time to form the hole and to cause this problem. CT imaging can be taken and it will show any air and fluid. Sometimes we are using the erect X-ray. So it will show like the bubbles, right? So distended loops of bowel and evidence of inflammation or abscess formation even, all of this can be seen. Sometimes you can do the X-ray and ask the patient to drink like fluid with a dye, right? Contrast material. So sometimes you will see extravasation of this contrast material outside, and it's more suggestive of perforation. Reoperating in presence of peritonitis, much more likely to require colostomy, right? If it's discovered during the procedure, it's much, much better because all this sequelae, it's not there. Like having peritonitis, having abscess formation or infection, it's not there. But if this is a situation, at that time, colostomy might be needed. And here, who will do the repair? It should be the bowel surgeon, not you, right? Yes, Dr. Mustafa, if needed and you feel like this area, the suture will not be or the stitch will not help, right? Sometimes even if you will do compression, it will help. With the cesarean section, it's less likely because usually the uterus, it's like the uterine arteries is like, like a hose, and the bleeding will be horrible sometimes. So try with a stitch and keep the diathermy your last resort. All right, so this is the bowel injury and how to recognize And if it's not recognized intraoperatively, how we diagnose? So we can do CT, we can offer X-ray with erect position to see the bubbles, or we can do with a contrast and we can see the extravasation of the contrast. Admit the patient, if she went home, admit the patient and ask for bowel surgeon review, and then re-laparotomy, fix the problem, keep her admitted, and we might need colostomy in this patient. For the post-operative ileus, it's like a lazy bowel. Usually are telling the patient it might be the lazy bowel. As per the enhanced recovery program, don't send any patient home while she's not able to open her bowel, because we don't know, is it just ileus or we have something serious, right? The patient will suffer from severe constipation and even the flatus, so nothing, and intolerance to oral intake, right? Due to non-mechanical causes after the surgery. It's non-mechanical. We don't have a cause mechanical like the injury, for example, right? Or the obstruction or the pseudo obstruction. As I said, the obstruction is very, very rare to happen to affect the bowel, except when to have. This is another answer for your question, Amani. When we will have like true obstruction, if we have a lot of adhesions and there is a band, and with the bowel handling, this band causing like true obstruction. This is only reasonable cause, right? So that's why like handle the bowel like carefully, and if you be able not to touch, don't touch, right? Sometimes with the post-operative ileus, it may be a normal physiological response to any abdominal surgery, due to the surgery, due to the anesthesia, due to the opiates as well. The patient will present with anorexia, nausea, vomiting, absence of flatus, pain, distension, and worsening from the time of the surgery. Like our patient now, she has the distension and she has this electrolyte disturbance. Still, we don't know, is it this or that? Intravenous fluid replacement should be given. Antiemetics should be given. Limitation of the opiates, right? Try to avoid the opiates, give another painkiller. Limitation of oral intake, used to manage the post-operative ileus as well. Give antiemetics, give IV fluids till this bowel will start to move. Patient with significant distension, we might need to go with nasogastric tube as well, right? And don't forget the electrolyte disturbance. So it's a common thing with the post-operative ileus. Post-operatively, actually, the hyponatremia is a common thing. And again, it was exam scenario. So how to manage, it's very, very important. And here the electrolyte disturbance should be managed. For example, here we have hyponatremia. So we need to give normal saline, right? And if you will give normal saline, check also the potassium. So if the potassium is low, so we can add like 20 millimole potassium on each bag till we will have normal potassium, normal sodium, blood sodium level. At that time, we can give like Hartmann solution, so we will not affect the electrolytes. So it should be monitored well. And it's rule, by the way. So you have to do that. You have to follow the electrolytes. You have to give the patient the fluids accordingly. Renal function, electrolytes should be checked. We just finished this in the previous slide, but it's here in the next slide. Abnormalities corrected, and as I mentioned, it's your rule, guys. Opiate analgesia, it's better to avoid or to minimize. The main diagnostic challenge here is to rule out the unlikely but more serious causes, like immediate post-operative adhesion formation, intra-abdominal sepsis, Ogilvie syndrome, unrecognized intra-abdominal or intraoperative, bowel injury, right? Immediate post-operative adhesions, less likely to happen. No adhesions will happen in one day. But as I said, it might be adhesion from the previous surgeries, and with the bowel handling, it will cause like true obstruction. So we need to rule out the most serious causes. This is the challenge in the ileus. Just to say, oh guys, now it's ileus. So be happy and reassured. Okay, so what we can do, we can offer abdominal x-ray. It's like useful initial investigation. We can check like the gas, and the gas here will be throughout the small and large bowel or intestine. It's not only in the large, so it's all through the tummy. You will find all the bowel distended with gas. So this more suggestive of paralytic ileus. Whereas if we have any like distended small bowel with no gas in the colon, so here we have mechanical obstruction. Here we have a band, and this band is like twisted, or the bowel like twisted within this band and causing this mechanical obstruction. X-ray also will allow the cecal diameter, which usually measured in Ogilvie syndrome. So if you can see it's dilated, oh, now think about Ogilvie syndrome, not paralytic ileus. CT can be offered, and it will give same information, but also will show any intra-abdominal collections, right? So that's why in the investigation, in the first slide in the management guide, I put scan, X-ray, and CT, right? So each one will give us like piece of information. And then, it's like a puzzle, and you will collect all the pieces, and by the end, you will have a clear picture. Put the clinical case, bloods, scans together. So now you collected everything, and you will have a clear picture. You can give correct diagnosis and manage accordingly. Now coming to Ogilvie syndrome. So Ogilvie syndrome, it's like acute large bowel obstruction. This is the definition. Without a mechanical cause. Your question, Amani, a mechanical or a true obstruction? It's pseudo obstruction, right? So it's acute large bowel obstruction without a mechanical cause, no band, no adhesion, no scar tissue. It's not specific only for the cesarean section. It can come with any patient going to any abdominal surgery, undergoing surgery. It has been reported in non-surgical patients as well, right? But with serious underlying medical condition, not a healthy person will come with Ogilvie syndrome. The exact pathophysiology is unknown. We don't know why this can happen, but it can be imbalance between the autonomic intervention of the distal colon. That's why we might need to consider neostigmine. This is the reason, because one of the theories that it might be autonomic disturbance, right? And this will lead to atony and subsequent dilatation. You got it? There should be a high index of suspicion in post-cesarean women with progressive abdominal distension. Keep it in mind, right? That's why in the ileus, the most challenge in the diagnosis to rule out the serious causes. We need to rule out the serious causes and then just be reassured and manage the ileus, and it will take its time. Initial management of the Ogilvie syndrome. Give IV fluids. Do you remember management of the ileus? We mentioned the same plus, right? So what is the same? IV fluids. Give analgesia. Again, try to avoid the opiates in case of it's like there is part of the ileus as well, like lazy bowel as well. Correction of electrolyte imbalance. Nasogastric tube insertion. It was plus or minus in the ileus, but here it's better to offer nasogastric tube. Abdominal X-ray can be done. We will measure the cecal dilatation. Early involvement of the surgical team, senior obstetrician recommended. Any patient you are suspecting bowel, involve them, right? Be safe and involve other people with you, other specialties, and your senior as well. Imaging usually shows grossly dilated loops of the large bowel, especially the cecum. So if we will compare the distension and dilatation of the bowel, if it's small and large, think about ileus. If it's only small, think about band or mechanical obstruction. If it's distended large bowel, especially the cecum with dilated cecum, think about the Ogilvie syndrome. I want this, guys, to be clear in the exam. You need to tell the examiner if you will have this patient in your department, how you will manage. If cecal diameter is less than 10 to 12 centimeters, conservative management will be of choice, and usually it will be successful. And we might need to consider neostigmine. For the cecal diameter greater than 10 to 12, the patient usually should have urgent clonic decompression. It's now dangerous. Necrosis can happen. So we need to do decompression. We can insert what we named rectal flatus tube. Or some of the patients will need laparotomy, and we might need colostomy as well. So most of the patients recover quickly, but if decompression fails, what we need to do, laparotomy and bowel resection, colostomy will be required. So now, is it clear now how serious this condition is? It's like a serious condition. It's not easy. Okay? So to summarize this slide, IV fluid, analgesia, correct the electrolyte, nasogastric tube to be inserted, offer abdominal X-ray, CT. Both of them will give us an idea about which loops dilated. We can measure the cecal dilatation. Involve the surgical team and your consultant as well. And if the cecal diameter less than 10 to 12, so conservative management will be of choice. Consider neostigmine as well. If the diameter 10 to 12, more than 10 to 12, at that time, think about decompression. Decompression can be done by rectal flatus tube, and if it's not successful, laparotomy, resection, colostomy. Okay, guys? So this is how you will manage the Ogilvy syndrome, and this is how you will manage this case. Do you have any questions?
Yes, please, Dr. Rana. Returning to the point guarding against thromboembolism, would it be better if I suspect like the differential diagnosis is internal bleeding to stop the low molecular weight heparin and give the heparin as it is short acting and I can reverse its action by protamine sulfate if I need to go emergent laparotomy or something like that? Would
Yeah,
it be a safety point for the patient?
you can do that, but actually the examiner will take you directly to the bowel. Now it's bowel involvement. What about your possibilities and how you will manage? Once he will tell the differential diagnosis, it might be bleeding, it might be this or that. If you want to add this point, so you can do that in the management, but already the examiner will take you to the bowel injury.
Yes, I mean, I just touched the point to stop numerical with heparin and to start heparin. That's it.
Yeah, you can do that. You can, instead, you can say we can do like bedside scan first to be sure that it's not bleeding. And if it's not bleeding, so keep the patient on low molecular weight heparin if you want to touch this point, right?
Can you say it again? What do you
So
mean
you
by?
can, yeah, you can tell the examiner we can offer a bedside scan. Bedside.
Ah,
So
okay.
the
Yes,
scan
yes,
machine, you will
yes,
put the scan
yes.
machine beside the patient and
To
offer a
exclude
scan.
internal bleeding. Yes,
Exactly. And keep
yes.
the patient on low molecular weight heparin.
That's a very
But
good option.
stop it, yeah, stop it before the procedure if you will take her back to theater.
Thank you.
You're welcome, Dr. Mustafa. Thank you so much. جزانا وإياك يا أماني. Thank you so much. Thank you so much, Shaima. Any other questions, friends? All right. So that's all for today. I will upload this recording so anyone who didn't attend, they can listen to the recording. If anyone needs the PDF, just send me a message on the group and I will give you access to this case. And if you want any other scenario, you feel like it's like difficult or tricky in the exam, just post on the group or direct message. So I can consider this to be my next station or next live session, inshallah. Right? Thank you so much for all of you guys. I will give the feedbacks for the 3 recording, hopefully by tonight or tomorrow, inshallah. You're welcome, Zainab. Thank you so much. Thank you, Banas, KMA, Saba, and Zainab, Isra, Zarina. Thank you so much, guys. Assalamu alaikum wa
Thank you,
rahmatullah.
Dr. Alaikum salam.
You're welcome.